Hey everybody, this is Avin and I'm going to give a quick talk on hypotension. So hypotension is very common, has a lot of different causes, and can be immediately life-threatening, which is why it's really helpful to have a well-practiced approach that you can deploy when you go to evaluate a patient at the bedside. And it starts with the physiologic understanding that the blood pressure is determined by a product of cardiac output and systemic vascular resistance. And if your blood pressure is low, either the cardiac output is low or the SVR is low. Mathematically, there's no other way around it. So what you should do when you first go to evaluate that patient at the bedside is go ahead and feel their shins and their forearms, trying to see if their skin is more warm or cold. Because if your blood pressure is low, the appropriate response should be to rev up those catecholamines, clamp down on those alpha receptors in the skin, and to shunt the blood inward towards your more vital organs. So if you feel the skin and it's actually warm, meaning that there's a lot of blood going there, the systemic vascular resistance is low, maybe that's why the blood pressure is low. So you find yourself in the category of so-called distributive shock or causes of hypotension. And I have a mnemonic to remember those causes. And it's kind of silly. It's SALTAS. It stands for sepsis or SIRS, anaphylaxis, liver disease, and specifically end-stage liver disease is a very vasodilated state. Vasodilatory toxins, and in the hospital most of the time that's medications. Adrenal insufficiency, spinal shock, and finally the last S stands for small or sleeping people, to remind you that sometimes hypotension can be physiologic and not a problem at all. So if you felt the skin and it was actually cold, that means the SVR is high, and mathematically it must be low cardiac output. That's the problem. All right, low cardiac output is determined by the product of stroke volume and heart rate. And it's good to look at the heart rate first because that's very quick. And if you find that the heart rate is 30 and you have acute bradycardia concurrent with the onset of hypotension, then that may be the cause. But if the heart rate is normal or high, then the problem must be stroke volume. And stroke volume is in turn determined by preload and contractility. So we'll talk about preload first, as that is actually maybe the most common cause of hypotension in the hospital. Okay. Here is another branch point that is not only helpful just in terms of pathophysiologic categories, but it's another place where an easy bedside technique can help you narrow the differential. So causes of low preload can be thought of as either actual situations of low blood volume, like bleeding, dehydration, third spacing, or overdiuresis, or they can be a problem with obstruction where the blood isn't getting back to the left side of the heart. And those are the so-called obstructive causes of shock, like a massive PE, tension, pneumothorax, or cardiac tamponade. And the bedside maneuver I was referring to is actually the JVP. Now, I know a lot of people aren't very comfortable evaluating the jugular venous pressure, but if you're exsanguinating and you're that hypovolemic, your neck veins should be pretty convincingly flat. Whereas if you have a big enough PE or enough intrapericardial pressures for you to be in shock, hypotensive, your jugular venous distension won't be subtle. So in this acute setting, the test characteristics of the neck veins for most clinicians are actually going to be quite good if you take the time to look. Finally, in the category of low contractility, You can think of this as essentially acute or subacute pump failure, and that is a subset of causes of more chronic systolic cardiomyopathy or systolic dysfunction. And here's another mnemonic in case it's helpful, and it is MATE for myocarditis. Whether that's viral or medication induced, it can be quite acute. Acute coronary syndrome, this would have to be a pretty big territory that gets knocked out. Toxins, which is again drugs, specifically beta blockers, calcium channel blockers, and especially in combination. And finally, electrolytes. Very severe acidosis or hypophosphatemia can cause acute myocardial dysfunction and loss of contractility. So to summarize, when evaluating hypotension, remember this hemodynamic Ohm's law. Look at the stroke systemic vascular resistance first by feeling the shins. If they're inappropriately warm and the SVR is low, that's why the patient is hypotensive. And the mnemonic SALTAS can be helpful to think of things that you might otherwise miss, like anaphylaxis. Whereas if the extremities are cold, that is a low cardiac output state. If it's not acute bradycardia, if it's not a clinical setting compatible with acute loss of contractility, then it's a low preload, which can be further evaluated with either very flat neck veins reflecting intravascular hypovolemia or elevated distended JVP consistent with obstructive shock.